hyperplasia of the vulvar region. Okay. It's a very easy condition to treat. Generally, we use some sort of fluorinated steroid that achieves two things. Fluorinated steroid will reduce the amount of chronic inflammation and itching. And also, the steroid will suppress mitosis of the skin cells in this area, so you don't quite get hyperplasia. Let's take a look at this. There's a section through the skin. Again, we have the epidermis here. There's the dermis. You have a dermal epidermal base membrane running through here. Typically, what we see is a thickened epidermis. Lots of these cells in the epidermis will proliferate and make the skin very thick. In the dermis, however, we do see a mild chronic inflammatory infiltrate, probably contributing to the pruritic nature of the disease. Again, this is all triggered by some sort of rubbing or irritation in the area. Let's take a look at the actual histologies. First, take a look at a section through normal skin. Here's a section through normal skin. We got the epidermis here. Then we got the dermis down here. You notice there's this interdigitating pattern between the epidermis and the dermis. You've got these parts of the dermis that stick up like this. Those are called dermal papillae. And then you got these little sections of epidermis that stick down. Those are called ready pegs. These ready pegs. And that interdigitation forms this very kind of convoluted architecture right at the interface between the epidermis and dermis. Now, everything looks good. Everything's in proportion here. You get a nice thin epidermis here. In lichen simplex chronicus, there's this constant irritation, constant itchiness. One scratches the area, mechanifies it, makes the area rough, and you get an extraordinary increase in the mitotic activity of the epidermis. That results in this epidermal thickening. So if this is what a normal epidermis looks like, this is what lichen simplex chronicus looks like. Again, a section through the area. You can see the epidermis here, and there's the dermis down there. You can see there's an incredible increase in the thickness of the epidermis. These ready pegs extend down the dermis much longer, and these dermal papillae stick up much farther. Okay. Got a lot of keratin here. There's some hyperkeratosis also that's present in the epidermis. Down here, if you could see it, there would be some mild infiltrated chronic inflammatory cells. Again, that just seems to contribute to the pruritic nature of the disease. It's very itchy. And again, you can treat that with a steroid. We generally use a fluorinated steroid because fluorinated steroids are a little more powerful. We just apply it topically to this area. That will reduce the inflammation, make it less itchy, and also inhibit mitosis of these epidermal cells. Reduce the epidermal hyperplasia. Any questions on that? Okay. Again, I just want to emphasize this is not a skin disease exclusive to the vulvar region. You see it in other areas. Sometimes the vulvar region will be hyperpigmented in the area that's affected. Sometimes it'll be hypopigmented in the area that's affected. It really depends on the stage of the disease. But the general nature is pruritic, and it leads to an increased thickening of the area. Sometimes the skin gets very tight in that area. If that happens, it can also cause dyspareunia, which is pain during intercourse. Dyspareunia, pain during intercourse. Okay, anything on that? All right, let's talk about tumors in the area. Remember, tumor just means bump. Doesn't necessarily mean a neoplasm. We'll first talk about condyloma acuminata. Condyloma acuminata is another name for venereal warts. It refers to these squamous cell proliferations that have kind of a verrucoid, a warty kind of surface. Often these lesions are likened to cauliflower. So often these lesions are referred to as cauliflower-like lesions. And of course, they are caused by various serotypes of human papillomavirus. Common serotypes that can cause this include serotypes 6 and 11. Those are actually the benign serotypes that cause cancer. Sometimes some of the oncogenic serotypes of HPV can also cause these cauliflower-like lesions, including serotype 16, 18, 31, 33. Let's take a look at these condylomas. Condyloma acuminata, again, these very warty lesions. You can see, again, the clitoral hood up here, and you can see the vulvar skin surrounding vaginal opening. You can see it's remarkable for these kind of warty lesions. Sometimes these lesions are referred to as verrucoid, meaning they're warty-like. More often than not, they're referred to as cauliflower-like lesions. You can see how these might resemble a head of cauliflower. Those are typical descriptions that are used to describe these condyloma acuminata. Just squamous cell proliferations caused by human papillomavirus. Now, in some women and in homosexual men, you can also see these condyloma acuminata in the perianal region. They're called anogenital warts. And here's an example. Again, the anus is here. You can't really see it because it's obscured again by a lot of these different warty lesions. Again, not uncommon. I've seen someone. Generally, you can confirm that this is an HPV infection by taking a biopsy. You would examine the tissue under light microscope. With light microscope, you can't actually identify the virus, but you can identify some of the cytomorphologic changes occurring in cells that are associated with viral infections. And in the case of HPV, you see a specific change in the cytomorphology of the cells called coilocytic atypia. Coilocytic atypia. Let's take a look at this. This is best exemplified by a specimen obtained from a pap smear. We talked about the different levels of maturation of the ectocervix. You get pap smear, of course, sampling the ectocervix. Over here, you got the spectrum of normality. We got 3 different layers in the cervix. We generally recognize 3 deep layers, called the parabasal cell layer. The next layer up is called the intermediate cell layer, and the most superficial is called the superficial layer. Remember, the cells deep down in the ectocervix are constantly proliferating. They are going to be the most immature looking cells because they're constantly proliferating. But as the cells migrate upward in the epithelium, they should be showing signs of maturation. You can see that here. Cells down the parabasal cell layer shown here. Again, you can see they're squamoid cells. They've got relatively large nuclei and a small amount of cytoplasm. So the NC ratio is rather high down here in the parabasal cell layer. Remember, high NC ratios are a sign of immaturity. Parabasal cells look immature. They should look immature because those are the cells that are proliferating, constantly replacing a lot of the squamous cells that are being sloughed off of the ectocervix. As they migrate upward, though, they mature. And you can see as they mature, they change their NC ratios. The cytoplasm gets big, nucleus gets small. You can even see some change in the chromatin pattern. In these immature cells, we have what we call an open chromatin pattern. Everything is a homogeneous, blue staining nucleus or chromatin pattern. That's because all of the genetic material is open, spread out, because it's being transcribed evenly. However, as the cell matures, you don't have to transcribe these genes. You can shut these genes down. So some of the chromatin, some of the DNA will actually clump together and will turn itself off. And you can see some of the DNA clumping here in the nuclei. This clumped chromatin is just areas where the DNA is no longer being transcribed. And this happens because as the cell matures, it doesn't need to transcribe its full complement of genes. It's starting to mature. All of the genes that are being expressed are simply maturing the cell. You don't need to express all of the genes all the time as the cell matures. The more the cell matures, the fewer genes you need to actually complete the maturation process. So these genes will shut down. And you've got these cells with higher NC ratios. Those are mature cells. The most mature cells are from the superficial layer. And you can see they've got a very small NC ratio. Nucleus is very small in proportion to the cytoplasm. They get very low NC ratio as an indication of maturation. You'll also notice the nucleus is very condensed. All the chromatins clump together. This cell is matured, doesn't have to do anything. And so it's closed transcription to all of its genes. All of the DNA is kind of clumped together. And the genes are in those areas are no longer being transcribed, which is most of the genome. Once these cells are mature, they're not very metabolically active. You don't have to do much. And so transcription is at a minimum. That's the spectrum of normality. Over here, you can see some examples of some abnormal cells. You do have one normal cell over here. It looks mature, small nucleus, big cytoplasm. But over here, you got some weird looking cells. And you can see they have a very large NC ratio. Nucleus is very large compared to the cytoplasm, even more so than the parabasal cell layers. And the morphology of the nucleus is kind of odd. It's not nice and round. It's kind of angulated. And you'll also notice around the nucleus, there's this clearing area. And it's called a perinuclear clear area, or a halo. All of these different features are collectively referred to as coilocytic atypia. Coilocytic atypia. And these cells are called coilocytes. And these coilocytes are consistent with an HPV infection. Okay, you see these coilocytes or coilocytic atypia. That's how you can verify that a person is probably infected with HPV. You can't see the virus itself, but you can see what the virus does to the cells, and the virus causes the cytomorphologic changes we call coilocytic atypia. Any questions on that? Okay, generally we manage these condyloma acuminata just by treating the symptomatology. There's not a whole lot we can do with the infection. HPV infects the tissues. We really can't clear the infection. There's no good antivirals that would purge the person of the HPV infection. The person's own immune system is going to have to do that. What we can do is treat some of the symptomatology. We can treat the presence of the condyloma acuminata. Usually we do that by enhancing the immune system's inflammatory response to these squamoid proliferations. We can put immune modulating agents on. There's a cream called Aldera cream that's very irritating. It's designed to be irritating. You just apply this irritating cream to the base of the condyloma, and the immune system will attack the condyloma and basically eventually shed. You can also use trichloroacetic acid wash. Sometimes that'll work, and again, the condylomas will shed. Because you are not actually treating the viral infection, there could be a recurrence of the condylomas. You can treat the condylomas, you can treat the symptoms of the infection, but you can't really treat the infection itself. And as a result, sometimes when you get rid of the condylomas, there are recurrences. Recurrences are very frequent, again, because you're not actually treating the infection. The person's own immune system has to do that. It may take a short time for the immune system to get rid of that HPV infection, or it may take a few years. Anything on that? Now, let's talk about some of the other complications of HPV infections. In addition to condylomas, sometimes HPV can cause skin dysplasias in the area, and those skin dysplasias will sometimes develop into squamous cell carcinomas of the vulva. Okay, here's an example of a squamous cell carcinoma of the vulvar region. Then you see a clitoral hood here, and you can see this white nodule here. This is a squamous cell carcinoma. Most of the squamous cell carcinomas that develop in this area are due to HPV infections. One of the oncogenic serotypes of HPV, 16, 18, 31, 33, it's usually one of those serotypes that would cause a squamous cell carcinoma like this. Now, this squamous cell carcinoma on the skin develops just like any other epithelial tumor. It starts off as dysplasia. Some skin is infected with HPV. The HPV causes dysplastic lesion. and the dysplasia will degenerate into an invasive cancer like this. Now, if we're lucky and we catch it early, we can cure this type of cancer by performing a wide area excision. Remember, the only way you're going to cure cancer definitively is if you do a wide area excision and capture all the cancer cells. If you can excise all the cancer cells, you can affect the cure. To do this, again, we need a wide area excision. This usually requires a vulvectomy. So we have to resect this entire area, including the clitoris. Take out all that area, that's a vulvectomy. And that is the wide area excision that we use to try to capture all the cancer cells. Okay? It's a mutilating procedure. If we don't do the wide area excision, there's a good chance we might leave some cancer cells in the area and it just be a recurrence, they can metastasize.
It's too difficult to like figure out just how much it's spread. So it's better to take a lot more than.
It's ultimately it's going to be up to the woman. I mean, you can see how close things are now. You could start off with a local resection and do what we call Mohs procedure. It's a microscopically guided surgical resection. What we would do is we'd start off just by, say, resecting this area, maybe an elliptical excision like that. What we would do here is we'd mark the borders. We would say, okay, this is anterior, this is left, something like that. And when we get the specimen, what we do is we carefully examine the borders of the specimen. And we'd be looking for any cancer cells that might be on the border. Let's say we see cancer cells on this border. Then we're going to tell the surgeon, you have to go back and you have to resect more tissue here. And then we're going to check the borders of this specimen. If we see cancer cells, you're going to have to go back and resect more. And then we're going to check this border. If we're going to keep doing that until we see no cancer cells in the border. Now we can do that. However, there's always a chance if we kind of try to resect this piecemeal that we're not going to really capture all the cancer cells. But that's a decision that the woman's going to have to make. Anything else on that? Okay. Again, this starts off as a dysplasia and can degenerate to a locally invasive cancer. The dysplasia is referred to as VIN, vulvar intraepithelial neoplasia. It is a neoplasm confined to the epidermis, the vulvar epithelium. Okay, so we call it vulvar intraepithelial neoplasia. This is just another name for dysplasia. Okay. It's by definition benign, but again, it can degenerate.
What age group is this typically occur?
I'm sorry, say again?
What age group is this typically occur?
For dysplasias, usually dysplasias are in the 30s, early 30s, and then cancers develop in the mid 40s. So it's usually a 15-year development. Okay. Let's take a look at some vaginal pathologies, genital anomalies of the vagina, total absence of the vagina. Some neonates are born with a blind ending pouch where the vagina should be. And on further examination, very often the vagina ends as a blind pouch because there's no uterus. And that could be a result of a couple of different things. Sometimes a fetus will present with a blind ending vagina and no uterus because they have something called androgen insensitivity syndrome. Androgen insensitivity syndrome, the fetus is actually genotypically male. You have something like a 46 XY karyotype. However, sometimes there's a mutation in the gene that goes for the androgen receptor. And the androgen receptor is not responsive to androgen hormones. When a fetus is developing in the uterus, its default gender is female. In order to change the default female configuration to a male configuration, you need an explicit androgen signal that has to operate on those receptors. If the receptors are defective and they're basically not listening, the default female fetus will continue to develop as a female fetus, but there'll be some irregularities. There won't be any female genitalia, internal, external. There'll be a missing uterus, and that will result in a blind ending pouch where the vagina usually is. And this is called androgen insensitivity syndrome. Typically, the person will develop as a phenotypic female, meaning to all outward appearances, the person will look female, but karyotypically, the person will be male, 46XY. Okay. Other things that we commonly see. Sometimes we see a septate vagina. This is a vagina where we see a kind of tough fibrous tissue that's dividing the vaginal canal in half. There you go. It's two halves. Usually this is a result of an incomplete fusion of the Mullerian ducts. The vagina develops as a result of fusion of the Mullerian ducts. You've got two ducts coming together. Sometimes they don't completely fuse, and you're left with this fibrous tissue that divides the vagina down the center. Okay, that's called septate vagina. It's easy enough to fix. You just resect the fibrous tissue, but that's another common condition. You see, here's what it looks like. Yeah, you see vaginal canal here, the endocervical canal, and there's, of course, the fundus of the uterus. This piece of fibrous tissue runs right up the vagina, right up into the endocervical canal. And all we have to do really is just resect that piece of fibrous tissue. Due to incomplete fusion of the Mullerian ducts. Any questions on that? Okay, vaginitis. Let's take a look at that. Very often, vaginitis is infectious in nature. There are different opportunities for the vagina to become colonized by pathologic bacteria. Antibodies, one big risk factor. There are normally lactobacilli that colonize the vaginal canal. The lactobacilli produce lactic acid, and they make the vaginal environment very acidic. And that acid environment is not favorable for growth of a lot of things, including certain types of yeast and albicans. As long as the vaginal environment remains acidic and the normal flora of the vagina is intact, you pretty much have a good protection against vaginal infections. However, you administer a woman an antibiotic, particularly a broad spectrum antibiotic, you wipe out the vaginal flora, the lactobacilli get wiped out. Now the pH of the vagina increases, and there are very few competing organisms in the vagina. And as a result, there is an opportunity for certain organisms to overproliferate, particularly things like Candida albicans. Candida albicans is a yeast, grows in yeast form in the vaginal canal. And when the organism overproliferates, a woman develops Candida albicans vaginitis. Usually Candida albicans vaginitis, you'll get a history of the woman having taken antibiotics, maybe a week before, a few days before. They generally will present with a history of pruritus and a discharge that's often described as a cottage cheese-like discharge. That's what it looks like. It's an example of candidiasis. Again, you can see we've got this kind of thick white discharge. That's classic Candida albicans vaginalis. And a number of different ways we can treat that. We can manage it with certain antimycotics. Common one is nystatin. We use nystatin to just wipe out the Candida albicans organism and restore the bacterial flora of the vagina. There are other things that you can do, but that's one of the antimycotics that we can use to treat this condition. No long-term sequelae, generally speaking. If this is kind of happens once in a while, it's not going to cause any trouble. But if it's chronic vaginitis, then the vaginal mucosa, the lining of the vagina, tends to become atrophic. And if the vaginal mucosa becomes atrophic, it can easily tear with any kind of trauma. So the only real consequence of this long-term would be if it's kind of a chronic condition. It will take its toll on the mucosa. Okay, other forms of vaginitis. Trichomoniasis vaginitis is caused by a protozoan. Okay, Trichomonas vaginalis. Okay, it's a little flagellated organism. This is an organism that's typically transmitted sexually to the woman. The organism, once colonizing the vagina, generally causes a malodorous, copious discharge. Usually it's kind of greenish in color, has a malodorous scent to it. If you take a sample of this discharge and you stain it, you'll see the organism Trichomonas vaginalis, causes trichomoniasis vaginitis. This is usually a sexually transmitted disease. The male will transmit it to the female. Often the male is asymptomatic. Male who's infected with Trichomonas vaginalis usually doesn't display any kind of symptoms, and that man may unknowingly transmit it to the female. The female, however, is usually symptomatic. They usually have that discharge. They'll notice it. Assuming the woman's not pregnant, it's easy to treat. Use metronidazole. Any questions on that? And then we got certain conditions where the normal vaginal flora can cause problems. Again, if the woman becomes immunocompromised or the woman's diabetic and has uncontrolled diabetes, then there's an opportunity for some of the normal vaginal flora to become pathological. And that causes vaginitis overgrowth. And the only really long-term complication of the vaginitis would be atrophy of the vaginal mucosa. Atrophy of the vaginal mucosa. Meaning the mucosa gets thin, it's easily torn. Let's take a look at vaginal cancer. Not a very common condition. In the past, the most common type of vaginal cancer was called clear cell adenocarcinoma of the vagina. This clear cell adenocarcinoma of the vagina was associated with an exposure to an artificial non-steroidal estrogen called diethylstilbestrol. In the past, the 50s and 60s, sometimes a mother would have trouble carrying a gestation to term. Sometimes she would have problems, spontaneous abortions, she would be able to carry the child to term. At the time, it was thought incorrectly, at the time it was thought, if you supplemented a woman with estrogen, artificial estrogen, it would help her carry the fetus to term. So this artificial steroid, this artificial estrogen, it's a non-steroidal estrogen, was given to women in the 50s and 60s again to help carry the gestation to term. Later, it was discovered that about 1 in 1,000 female fetuses exposed to this artificial estrogen in utero, would subsequently develop a type of vaginal cancer we call clear cell adenocarcinoma of the vagina. The clear risk factor was in utero exposure to this artificial hormone called diethylstilbestrol. Let's take a look. Here's an example of clear cell adenocarcinoma of the vagina. You can see why we call it clear cell adenocarcinoma. First of all, it is an adenocarcinoma. It forms glands as it grows. And you can see the cells don't stain very well. So it's clear cell adenocarcinoma. The risk factor here was exposure in utero to diethylstilbestrol. Now, we actually don't use diethylstilbestrol for this purpose anymore. In fact, the whole use of diethylstilbestrol was actually based on a misconception. The hormone was actually not helping women carry the gestation to term. So we would no longer use diethylstilbestrol for this purpose. We do use it in men to treat prostate cancer. Prostate cancers are hormonally responsive. They respond to androgens. Under the influence of androgens, they tend to grow faster. And so to reduce the growth of prostate cancer, we antagonize the effects of the androgens with this estrogen, diethylstilbestrol. Actually has a remarkably good effect on reducing the growth of prostate cancer. So we don't use it anymore in women, but we certainly use it in men for prostate.
There's no side effects for guys using it?
Yes, there are quite a few side effects. It's very often it's likened to a medical castration.
Mhm.
There are definite effects of not having a certain level of estrogen maintained, like secondary sex characteristics.
Mhm.
And now you're taking estrogen, which is in favor of female secondary sex characteristics. Okay, anything else on that? All right, then. Let's take a look at the cervix. Okay, this is the most common site of cancer in women. Now, the cancer that's most likely to kill a woman is still lung cancer, but the most common type of cancer that develops in a woman is cervical cancer. Most of these cancers are squamous cell carcinomas, and at least 90% of them are associated with HPV infections, the typical oncogenic serotypes. Okay, let's take a look at a normal cervix. Okay, let's going to take a look at normal cervix right here. This is an example of a normal cervix. You can see a transverse section to the vaginal canal. There's the vaginal canal. You can see the uterus right here. There's the cervix, of course, and there's the uterus in the background. There's the fundus. Take a look at the cervix. The exterior of the cervix you're looking at here is called the ectocervix. You recall it's being invested by a stratified squamous type of epithelium. Okay. Usually, most of the cervix is invested by the stratified squamous epithelium. Right in the center of the cervix, we've got what we call the cervical os. The cervical os opens up into the endocervical canal, and the endocervical canal leads all the way up to the endocervical canal. Okay. This is the way the cervix should look if it is healthy. It's generally described as being smooth, okay, and it's glistening. It's not, doesn't have a rough surface. It's very smooth, and therefore it glistens. When you see a cervix like that, or generally any cervix like that, it's generally consistent with a lack of inflammation. Everything is fine. There's no inflammatory process there. We can begin to talk about cervicitis. One of the complications of cervix is that it can get inflamed. There are many reasons why the cervix might be inflamed. Often the cervix gets excoriated during birth. You can get infected with things like staph and strep, but there are actually other reasons why the cervix can be inflamed. One of those reasons would be in the Bothian cyst development. The Bothian cyst is a common condition caused by a overgrowth of squamous epithelium blocking endocervical canals that normally produce mucus. These endocervical canals get trapped under the squamous epithelium. They're still producing mucus. The mucus get nowhere to go. And so the mucus kind of collects in a little cyst. We call those Nabothean cysts. Okay. This is a very common problem. I've actually never seen the product of an adult hysterectomy that didn't have one of these Nabothean cysts somewhere. Okay. The Nabothean cyst is actually the result of a rearrangement of epithelial cell types in the cervix as a function of a woman's age. When a woman ages, the type of epithelium that invests different parts of the cervix will change. Let's take a look at this. We have a depiction showing you the different types of epithelial cells that invest the cervix as a function of age here. Here we have a depiction of the cervix, vaginal canal, the cervical canal. When a woman is just born, a female neonate. Again, there's the vaginal canal right there. That is, of course, the cervix. We've got the cervical os here. There's the endocervical canal and the endocervical canal here. When a woman is born, a female is born, the ectocervix is invested by a stratified squamous epithelium. Okay. Beyond that, we have in the endocervical canal a type of epithelium that's described as mucus-secreting columnar epithelium. Okay, that's what the cervix looks like at birth. Its entire exterior is invested by a stratified squamous epithelium. Now, the distribution of those epithelial cell types will change as the woman ages. As she approaches young adulthood, this stratified squamous epithelium here will regress, and it will be replaced by this mucus-secreting columnar epithelium. So the time she reaches young adulthood, this is the distribution of the epithelial cell types. Again, you have a regression of this stratified squamous epithelium. What's taking its place is this mucus-secreting columnar type of epithelium. And so when the woman is very young, part of the ectocervix is actually invested by a mucus-secreting type of epithelium instead of the stratified squamous epithelium. Okay. Now, the problem occurs when she gets just a little older. She reaches adulthood. Again, there's a redistribution of epithelial cell types. What happens is that this mucus-secreting columnar epithelium again recedes, and it's replaced by the stratified squamous epithelium. Now, problem occurs in this stage. Sometimes, as the mucus-secreting epithelium is beginning to regress, the stratified squamous epithelium overtakes the retreating mucus-secreting columnar epithelium, and as a result, it gets trapped under the stratified squamous epithelium. And it still produces mucus. And the mucus gets caught under there, and it forms a little mucus-containing cyst called a Nabothean cyst. Let's take a look at this. Here's a section through the cervical os. So you got the vaginal vault is out here. There's the ectocervix. Okay, it's invested by a stratified squamous epithelium. This would be the beginning of the endocervical canal. Okay, you can see the stratified squamous epithelium of the ectocervix gives way to a mucus-secreting columnar epithelium. This is called the transition zone right here, where you get change of epithelial cell types. Everything is okay here. Take a look at the endocervical canal. That's where these mucus-secreting cells and glands are. This is the endocervical canal. You can see these mucus-secreting columnar cells, that little glands that produce a lot of mucus. Now, again, when there's a redistribution of epithelial cell types, particularly when a woman goes from young adulthood to adulthood, this epithelium is receding and the stratified squamous epithelium is overgrowing. So sometimes stratified squamous epithelium will overgrow one of these glands. And that gland is producing mucus. It gets trapped under the squamous epithelium and again makes a little cyst that we call Nabothean cyst. This is what it actually looks like. Okay. Here's a section through half of the cervix. There's the endocervical canal here. This is where the cervical os would be. This is the endocervical canal. This is the ectocervix. And you can see most of the ectocervix is invested by a stratified squamous epithelium. But if you look underneath the epithelium, you can see those. These are mucus-containing cysts. These are the Nabothean cysts. And you can see there are multiple Nabothean cysts. Very common condition. Again, I don't recall ever seeing a product of a hysterectomy from an adult woman where there haven't been at least one or two of these. Okay. Now, the problem with these Nabothean cysts is that they can incite inflammation. They can cause focal cervicitis. And you can see that on a colposcopy. That's a kind of a close-up look at the vaginal canal and cervix. This is what it looks like. Here's a normal cervix. Again, there's the vaginal wall. There's the cervix, cervical os. Normally, it would be smooth and glistening. Here we have a cervix with Nabothean cysts. You're going to see areas of irregularity, and in these areas, probably the red, the erythematous, because of the local cervicitis. This is what it actually looks like. This is a colposcopy. There's the vaginal wall. There's the cervix. That's the cervical os. This is the ectocervix. Most of it you can see is smooth and it's shiny. But over here, you'll see these bumps here. And they're very erythematous. Those are the Nabothean cysts. Underneath that stratified squamous epithelium, you've got an accumulation of mucus. All right, any questions on that? Okay. That's it.
So